Let's see. There we go. Thank you. It's 9:02 Central Time, 10:02 Eastern Time. This is January 21st, 2022. This is the Physician Technical Advisory Committee meeting under auspices of Title 19. I'm here today with a quorum. Let the minutes show that I'm here, joined by Dr. Gupta and Dr. Neal. That'll give us a quorum today. We have staff on board. In particular, we want to welcome Cody Hunt. Cody's working with us, and Cody spent a lot of time getting ready. Cody, I really appreciate your work getting ready for today. Thank you very much. You're welcome here. We have a good agenda today. Let's call the meeting to order, and then our first item will be approval of minutes of the last meeting. Is there a motion to approve?
So moved, Dr. Neal.
Dr. Neal, second.
A second, Dr. Gupta.
Dr. Gupta, all in favor? Without objection, the minutes are approved. Let's item 3, old business. We have one item for old business. That's the update on DMS Medicaid limits for complex E&M visits. Cody, can you set that up for us, please?
Sure. So just to quickly introduce myself, my name is Cody Hunt, and as of December, I'm the new health policy manager at the Kentucky Medical Association. So I look forward to getting to know each of you, and I look forward to working with you. So to begin, this is an issue that predates my role here and is an issue that this committee has discussed in this space with DMS over the course of the past year and a half. So today, the committee would really just like to get an update from DMS on where they are with any potential changes or any considerations that could be coming to the administrative regulation that governs this policy, which again is 907 KAR 310. And just to refresh everyone, the problematic portion of this administrative regulation that's been discussed in the past states, quote, except for chemotherapy administration to a recipient under the age of 19, reimbursement for an evaluation and management service with a corresponding CPT code of 99214 or 99215 shall be limited to 2 per recipient per provider per calendar year, end quote. So during the interim, under the direction of Dr. Thornberry, we've looked into how our surrounding states Medicaid programs treat complex E&M visits. And we found that the vast majority of them do not appear to have any limitation on these visits. So of course, we'd be happy to share this information with DMS if it would help further the conversation. And with that, I will turn it back over to you, Dr. Thornberry.
Dr. Thornberry, are you on mute? No?
I think he is. I can't hear him either.
I am sorry. I was trying to give Cody the floor there. Thank you. This is an issue that we've brought up a couple of times. And I think the concern here is that I admire when 10 years ago, when this was set up, I admire the generalship of saying, well, we're going to try to limit our downside if you're an MCO provider or a partner of ours. But I think at this point, what's happened is, particularly in Kentucky, it's become deleterious, and it's having the opposite effect. It's demoralizing your primary care. And I'm not talking about the maybe clinics out there. I'm talking about the people that are doing the serious, the diabetes, the COPD, the hypertension, and that's your primary care workforce. And what happens is these people come in, they have transportation difficulties getting in. When they do come in, they have literally a litany of things that they want to try to accomplish in one visit. And trying to do that, it may not make sense bureaucratically. You say, well, we'll just schedule another visit. But when you do that, those things don't occur. These people don't come back. They can't come back. There are multiple problems. So we end up dealing with multiple complex things in any one visit. Now, the government asks us to code properly, which is in coding, when we take care of now with the current recommendation, the current guidelines, when we have 2 stable chronic medical problems, so say high blood pressure with thyroid disease or cholesterol with diabetes. Well, if they're stable, that in and of itself is a 4. Well, in my office, we hardly ever get that. I mean, we get diabetes, hypertension, dyslipidemia, their shoulder hurts, and there's something on their skin, and they want to refill on this, and that happens. That happens, I'd say 4 times before 9 o'clock in my office. And I guess the greater point here is when you're asking, when you're asking your primary care workforce to shoulder the burden of this, and you're not compensating them because of somebody slipped in a nice little modifier to a regulation. Well, that again, that deteriorates the morality of the work that they're doing. And everybody's in on the game. Everybody understands this. I've heard this over and over again. I think we asked Cody to look around the surrounding states. When Cody says that, well, pretty much none of them are really doing this, that means nobody else is doing this. They pulled a fast one here in Kentucky is what it seems like. Dr. Neal has a lot better perspective than I do. Our emeritus chair, Dr. Neal, could you lend some wisdom here?
Dr. Thornberry, this is Charlotte. I think we have somebody from DMS that may be able to give you an update from us if you'd like.
I'd welcome that. If they're prepared, I'll turn the floor over to them.
Justin or Jonathan? Justin, did I see you coming on?
Yes. Hi, good morning. My name is Justin Derringer. I'm the Assistant Director with the Division of Policy and Operations for the Department for Medicaid Services. And I don't have a concrete update today to give to you. I know that's probably not what you wanted to hear. I can tell you that we have been meeting about this topic, discussing this topic, and I think, we understand the issue and what the surrounding states are doing. And I think we should have something to come back with you very, very soon. The regulation is open, hasn't been filed with LRC just yet, but the promulgation process has started. We have made some changes, and we will probably most likely, Jonathan's not here. He's our regulation expert, so he could tell you exactly, but I would assume that we would send a copy of that draft regulation to you all to pre-review before we file that with LRC. And so you all should be seeing that very shortly. That's the update that I have.
Well, we appreciate that, Justin. Thank you.
You're welcome.
Does anybody else, I don't want to belabor the topic, but does anybody else have any thoughts on this?
Oh, Bill, am I unmuted? Can you hear me?
No, I can hear you, Dr. Neal.
Yeah, we have debated this till we're out of breath with it. And there's no sense in our wasting our time until we find out if we're going to be happy with what they're going to send us, because we're so far behind it. It's bigger than this because we're underpaying at 214 levels. So we're ready to move on with that. But we've got to get to this. The new guidelines are that 213 should be about 40% of visits and 214 60%, or vice versa. It keeps changing. And we know that that's gamesmanship that everybody's playing. And we've just got, Justin, can you at least tell us if you think we're going to be happy with what you're going to advise? Is he still there?
I am. I don't think I'm really prepared to
Okay.
today. But I think it'll be. I think it'll be good. I mean, I don't know. In the regulation, in the promulgation process, we have to come to a complete agreement within the department and then within the cabinet level before we're able to share those, because it's an administrative regulation. If it was a policy change or something like that, it would be a lot easier to change just based on conversations, and we can do that at a division level. But because it's an Kentucky administrative regulation. We have to get approval from all of our upper management before we're able to start sharing that with, you know, with our stakeholders. But I think we're there. We're at that, you know, we're at that level. We just haven't got the final, all right, go ahead and send this out yet. So that's coming very, very soon. And I don't think there'll be a ton of back and forth on it. I think it'll be good, but I really can't speak a lot to it more than that.
We understand your position. Is the commissioner on with us today, or anybody that can speak to it? That is anybody else?
I don't see the commissioner on today.
Okay.
This is Dr. Terrio, and I just wanted to let you guys know we hear you and we understand. So Dr. Thornberry, Dr. Gupta, Dr. Neal, we are, I think, pretty much on the same page, and we're working on it.
Thank you, Judy. We really appreciate that. And I saw you pop in. Well, if I don't really want to beat this horse any further, I think we all are kind of, at least in our position, we're of like mind here. And again, I think we want a more efficient system. If it's okay, I'd like to just move us on to new business. Does anybody object to that?
No, that's fine.
Okay, well, let's go on to new business. We have a couple of things. The first item I asked to bring up was just a presentation on the telehealth Medicaid program. And the only reason I'm interested in talking about that, I'm not interested in embarrassing anybody or putting anybody in a bad position. I just want DMS to understand that the physicians, in particular, I am committed to trying to lower our cost burden in Kentucky. And this whole program was designed to try to move us in that direction. The reason that we brought telehealth in is because I saw that we are going to have a more efficient model of delivery. And that's only good if it's working. And if it's not working, then we've got to make some changes. And because 1 in 3 Kentuckians are in this program, it could go bad in a really big way, and it could go bad quickly. That's why I'm interested in talking about this. I'm really coming from the position is we want to try to help you and try to help understand, at least from our view, are we going in the right direction? Cody, can you give us a thumbnail on this, please?
Sure. So to kind of just frame it, provide a general overview, going back to 2018, thanks to the leadership of Dr. Thornberry and Senator Alvarado, the General Assembly passed Senate Bill 112, which really enabled Kentucky to be the leader in telehealth policy, as we all know. And then, of course, with the COVID-19 pandemic, we saw the great benefit of telemedicine. And due to this, and thanks to the leadership of Representative Frazier and Representative Moser in the General Assembly, they made further improvements to our state's telehealth laws by way of House Bill 140. So today, Dr. Thornberry just wanted to see if someone from DMS or CHFS would be able to present or provide an overview of the utilization report that was required by House Bill 140, and further speak to several specific data points about the telehealth program in Medicaid. And we thought that the House Bill 140 report would just be a good starting point for discussing the telehealth data that CHFS is collecting. And I believe the last time there was a discussion on telehealth data in this setting, it was nearly a year ago, and the state really hadn't had time to truly compile our 2020 data, and certainly not the 2021 data. So with that, I will turn that back over to you, Dr. Thornberry, or Medicaid, whoever wants to chime in.
Well, thank you, Cody. Again, I think the overlying philosophy, and I received the information. I want to thank DMS for being very forward about that. And I looked through it. I don't know what to say about it. What I'm trying to accomplish is moving as much chronic disease care online as we can. I think that is the opportunity that we have for savings. I think trying to move acute care online can save a few dollars. It may save a few dollars. It may cost a few dollars. It's going to be I just see that as a push. But I say the real opportunity is keeping people out of the ER for chronic disease, keeping them out of the hospital for chronic disease, asking the families to obtain care earlier when things are not going well. And again, there's a transportation cost that's kind of, it could be significant, but it's kind of nebulous. And I appreciate the fact that we're still into this pretty early. But I would just open up to our DMS colleagues and see if there's anything that they could, do they have any guidance on this for us? Do they have any intuition on this? I'll open the floor up for discussion.
Well, I would like to, I'm gonna try to share a screen here. I think we're sharing Charlie's right now.
Yeah, Justin, let me stop sharing
Okay.
mine. You can, now you should be, oh, wait, I probably have to make you as a co-host. Hang on.
All right.
I forgot you had a presentation. I usually try to do that at the very beginning. Now you should be able to share.
All right.
We can see it.
Okay, good, good. So getting started, this is just a brief presentation on telehealth that we've put together. I want you all to know before we get started that we have quite a bit of other data that we're reviewing, that we're looking at specifically in cost savings and cost comparison ratios that we'll be able to share at a little bit later date. That's not necessarily available today, but we'll get started with this. This is a trend. If you'll look at a percent of increase, and you'll see the two data points for dates is March of 2022, August of 2021, and you can see the behavioral or the billing type, provider type. Of course, that's the way we break things down here in DMS is by provider type as far as billing goes. And you can see the percentage increase based on that provider type of for the telehealth trend. Now, this is for fee for service only, doesn't include MCO data. We can see our BHSOs with the highest percentage increase, followed by multi-therapy agencies, definitely the top two. And you can kind of see how it goes down. Even there toward the end, our certified nurse practitioners with 144% increase in telehealth usage. To put that in a just a graph form for visualization, you can see the increase there. Quite a bit of increase and usage. The next part here was the MCO trend. As you can see with the MCOs, a little different story, still broken down by billing provider type, individual physicians followed by physician assistants. We're definitely the top two increase percentage wise. Those are huge increases in the use of telehealth, which are good. And individual physicians definitely taking advantage of that. So those are some of the trends on who is using telehealth the most, which provider types, which groups, and how big of a percentage increase those were since 2020. Again, here's a chart to kind of visualize that just a little bit more in some different areas, showing the increases and growth for different provider types throughout the different data ranges on dates. We can look at the some takeaways, fee for service versus MCO trends. We see for fee for service, the BHSOs are had the primary increase in telehealth usage. However, all provider types with fee for service and MCOs both had significant increases in telehealth usage during that time period. For MCOs, individual physicians definitely had the greatest increase in telehealth usage. And we look at for fee for service for the behavioral health organizations, using telehealth to be able to reach individuals that sometimes may not be able to be reached, that may not be able to make it into the office. That was definitely a key takeaway and benefit for their usage in telehealth as it increased throughout that time period. And that's that presentation. I also have, and we'll start again with fee for service here. This is a member count, amount paid, and claim amount, and that's just a small graph to kind of show you the fee for service trends during the data ranges. You can kind of see when telehealth started and when the COVID surge hit the hardest. Those telehealth numbers, of course, peaked telehealth usage, and it's kind of dropped back down.
Justin,
Yes.
this is Charlie. I'm sorry. Are you trying to share another one? Because we're still seeing the last slide of the.
Okay. I'm sorry. Yeah, let me correct that. Is that better?
Yes, sir. That's much better.
I apologize.
No, you're fine.
So again, just a visualization, a chart to see the surge in usage, amount paid, claim count during the COVID surge, and then kind of a drop back down to more baseline, I think, when individuals started coming back in to the offices. This is fee for service. And I don't know if you all have this information, but if you don't, I will send it to you after this meeting. We break it down by service month on this one, and it has the member count, claim amount, and amount paid. We start March of 2019. We end with November of 2021, and you're able to kind of see from that how the trends went, and for fee for service. We did the same thing with MCOs. You can see the graph shows a similar story for MCOs, a little higher usage rate continuing than fee for service. Fee for service dropped down a little more than we kind of expected. So you can see that the peak is around the same with the surge in COVID-19. But then we seem to, after that, kind of leveled out, plateaued out with the usage and claim amount for telehealth with the MCO data compared to the fee for service data, which seemed to drop down quite a bit more. Again, same data points and data ranges as far as dates there on those slides. So those are two of the pieces of information that we pulled for fee for service, also for MCOs. Again, we have more data that we're reviewing as far as cost savings and comparison on how much money was actually saved on the state side, and also on the physician side or provider type side. And we'll be getting that to you all very shortly.
Thank you, Justin. I thought that the last slide was particularly good. I think the two things that my takeaway was, firstly, with the passage of 112, I can't believe anyone foresaw COVID. And that really put everybody into the bucket. And so all the providers, I think, that are out there in Kentucky now have some type of way to conduct telemedicine. And we wanted that. We just kind of got thrown in the deep end of the pool pretty quickly. So I think we've been successful in implementing it much sooner than I thought we thought it would happen. But the second slide, it looks to me like now the last 6 months that those claims have come off, if I recall, maybe it's 50,000 claims. But, it's kind of settled in a little bit of maybe the providers in Kentucky are seeing the role for them that the virtual clinic is going to provide. It's not going to solve all the problems. It's going to solve some of the problems. We just wanted to solve it in a way where it's going to save money. So I appreciate that. Ashima, Dr. Neal, would you all have some thoughts on this?
Ashma, go ahead, then I'll speak. She's still there.
I'm here, yes. In my personal practice with ophthalmology, it is a bit difficult for us to use telemedicine. We did during the 6-week closeout on the beginning of the pandemic for certain cases, but otherwise, I see very high value in telemedicine. I think that, I totally agree with everything that you're saying.
Bill? Yes, well, of course, Bill, you and I have been doing telemedicine for ever since we've been in practice, as long as there's been a telephone, and we just weren't able to see our patients at that point. So dermatology has come into play there quite a bit. But anyway, I think telemedicine probably kept some doors open that couldn't have kept open during COVID because people couldn't come to the office, wouldn't come to the office. And that's still an issue. We still have mothers afraid to bring their children into the office or even their teenagers unless they have to. And it's a real special problem for us because we really can't do much telemedicine for well child under about age 3 because there's so many things we have to check for. And the Academy of Pediatrics has come up with guidelines which said if they can come to the office, they don't need to do telemedicine. And then a note needs to be made onto the chart when you do telemedicine on a well child that there were certain things that couldn't be done that need to be followed up in the office. I'm sure Bill understands all of that. So that's been a real concern, and I just don't want telemedicine to get out of hand. Certainly, we're seeing a lot of teenage mental health problems now with COVID, depression, and that sort of thing, and telehealth is helping that. No doubt. I see there's a bill before the legislature now that has to do with kids missing school because of mental issues, and most of that's going to be a telehealth visit, I think. So there's just a myriad of things that we need to discuss, but we got to be careful and not let it take the place of the in-person visit. I'd love to hear your thoughts on that, Bill.
My hope is that it won't take the place of the in-person visit. My hope and the way that we've worked with this is, again, more of the way Toyota would work with lean systems. They will take the more complicated things that have to be in the office and place them in the office. The things that don't need to be in the office, that would just take time and structuring and logistics, we're going to move those online so that we can take care of the people that need to be there. I think if you were a patient, the way you would see it was when you called, you could come in to see the patient, the physician or the provider today. You wouldn't get put off a couple of days or a couple of weeks. It would just say, well, we have room for you. And that would be the gold standard. And I think the people that do that work better than anybody, probably Kaiser out there in California. KP's done a lot of work in this area, and about 50% of their interactions are online, at least in primary care, that is. And so if you over several years, if we mature to that, that would tell me the kinds of things that need to be seen in the office can be done in the office. I don't want to go too far before I say, Charlie, I do not know what we're going to do without you. I'm just saying. I hope that you enjoy your retirement, but we're really going to be in a bad spot here in our committee.
Well, I appreciate that, but I'm sure they will have someone who will probably even do a better job.
I don't see how, Charlie. I don't see it.
Well, I appreciate that very much.
Well, you're very welcome. Cody, you and I spoken offline a week or so ago about just some things that I would look at intellectually. And these are not things that I think our committee's requesting. I just want to put this out there for people like Justin in his position so that he can see things the way we see it. Do you have a few things that I would follow if I was looking at the data as it came in? But maybe we could just mention out there just in case they might want to use this.
Sure. Let's see, one of the metrics that has been discussed in recent publications was success rates of telehealth visits, looking specifically at sociodemographic factors, how those are influencing visits. And then one of the other ones was if we have a way of gauging or a metric to look at the percentage of chronic disease care that's going online. And then finally, really just looking at the encounter rate per enrollee, is it going up or down? And then is the cost, per enrollee going up or down as it relates to their utilization of telehealth?
And Justin, I'm sure I don't want to step on your toes here, but that's really what you guys do. But I think what Dr. Neal pointed out earlier is, for example, are we seeing more visits just to see more visits? Is the average encounter staying about the same, or are we able to actually reduce that? Is the average cost, I'm sure we know this, there are people there that know it to the penny, but is the average cost per encounter, is it over time going down, or is it coming up more than expected? And so those are kinds of things that we would look at. Again, the last thing is, I don't know if you can parse the data, but it would really be important to me if I was on that end to say, are our chronic disease care encounters as a percentage, are they going up online? Because that would be a good thing. That would be the fact that the physicians and other health professionals understand it. They taught this to the families understand how to use it. That would be a very mature way to understand if telemedicine was actually working properly in a place like Kentucky where there's a lot of chronic disease burden. So we thought we would just pitch those things out there to you in your work to see if that is some type of makes some type of sense to you guys. It would make a lot of sense to me to understand those kind of numbers from year to year.
No, absolutely. And those are some of the things that are taking just a little bit longer to kind of piece out and put together. But that kind of information, that kind of data is data that we can piece together from claims and other information that we gather. And so putting that in a viewable, accessible source to be able to track trends and see what's actually going on with the cost and who, are chronic patients taking advantage, those type things, what percentages of which types of patients are using these services. All that information is, we see that as being extremely beneficial data for you all and for us as well. And so we're working on those things. Those are some of the things, as like I said earlier, we're working on. Just not completely ready to share just yet, but we will be very soon. And so I think those will be very interesting, but they'll also be very helpful and beneficial for us in creating policy and looking toward the future. And I'm sure for you all as well.
Well, we want to keep our commitment to you and to DMS and the administration that as we move through this, we're going to try to be equal partners for you to help solve this problem and give you as much insight from our position as we can. Again, our goal is to try to make this an affordable program for the Commonwealth and sustainable. And I think that not only will you have the interest of us, I think you're likely to have the interest of a lot of people around the country, because if we're able to solve this, a lot of different states are going to come in and ask how we did it and what was our secret sauce. Well, is there anything else on this topic? It sounds like we're at least getting the ball moving. Anything else before we move on?
Bill, I just want to make one quick point.
Yes, sir.
We primary care docs have always been accused of, we want to see more patients just to make more money. Well, that's almost laughable because we're just trying to keep our doors open. And it is just a joke, because just the advent of the electronic medical record took the pediatrician from seeing 40 to 50 patients a day down to 25 or 30 a day. And telemedicine has just helped. It doesn't even pay for the electronic medical record costs that we're dealing with right now. So this is a really complex thing that we're talking about. So I just want to make that point before we move on, because yes, Bill, you said we want to be equal partners to DMS, but we want them to know. I think somebody said that the physician component of the Medicaid budget is like 3%. some ridiculously small? Justin, can you give us an answer to that?
I do not have those numbers in front of me
Oh,
right now, but we can get you
okay.
those.
Okay, by the way, I just want you to know with the light behind you, you look like one of the 12 disciples and the light from heaven is coming down behind you. So anyway, I just,
That
you
was intentional. So no,
Okay.
that was not.
all right, okay. We
I
all need that
apologize.
light. We need that light from above right now, believe me. Okay, we're
But-
just fighting in our town of Owensboro, we're fighting to try to get primary care providers, and I hate to use that word, clinicians, I'll say, because our access to care is deteriorating. People with COVID, for example, can't even get in to be given the okay to get antibodies, you know, that sort of thing. It's just really bad. So you need to know what's happening. And I'm in the 4th largest city in the state. What's happening out there in the rural areas? So Bill, you might speak to that a few minutes before we move along. I think it's important.
Well, I want to respect what we're trying to accomplish. And I don't want the conversation to seem like we're trying to injure our work partner, which is DMS.
Oh, I understand.
Short of generic medications. If I'm not mistaken, I think Barbara Starfield's model of thorough primary care has never been disproven in 30 years that I've ever been working. And that would be the more primary care you have, whether it's on a local level, a regional level, or a state-based level, those health systems are the most economic, which means they perform better outcomes at lower cost, and it's never been disproven. In Kentucky, again, if we're spending 3% of our resources on the primary care workforce, the way I would look at it is we have a real opportunity to try to improve that, because as you improve that number, you're going to get better outcomes. I wish I had some hard data for you. The last time I remember, somebody up in New Jersey did some work on this. You know, Jerry Stover with the KAFP, Jerry would know something like this. But those people that did that work showed that for the investment that they put in primary care, they were getting substantial investment down the road, as in lower cost and better outcomes. And that's kind of what we want. It really is laughable to try to think that physicians or other providers are trying to see more patients to generate more money. It's actually the opposite of that. I think we're trying to keep people away from the health system for a number of reasons. And that kind of, I mean, again, without going too far on this discussion, it really kind of brings us right into the next step, which is how can we help these people do their job? Because these guys are saving us money. If I was DMS, that's the way I would look at it. I'm like, well, these primary care people, they're saving us a bunch of money. What can we do to make their life better? That would be one of my take homes. I'll take us, if it's okay, I'll walk us into our next business item, which really dovetails into this, which is prior authorizations. Is that okay with everybody if we move on here?
Yes, fine.
Okay, so prior authorizations, I thought I woke up this morning and I thought I would just kind of give you a little bit of an example instead of an ethereal, yapping about some type of problem that we're having. I want to tell you about a case that really happened yesterday and last night. So we had a lady come in, and this lady is a beneficiary, and she tells us she's had like 20 falls in the last week. And when you hear that, she was initially scheduled for something else, but she goes, well, I want to talk about this. And we go, well, we want to talk about this too. And unfortunately, this lady has an underlying really serious metabolic problem where she's going to be required to be on some anticoagulation. And so when those kind of people fall, what you need to understand is they are put at risk for some serious internal bleeding or bleeding, subdural bleeding from the brain. And that gets to be a very serious issue. Well, that being said, the first thing we wanted to try to do was we wanted to say, well, can we get this lady imaged? We're going to have to figure out why she's falling. It looks like she's having some weakness. Maybe she's bleeding in her low back. Maybe it's putting some pressure on the spine. Maybe she's becoming ataxic. She's going to need a CT scan. And in doing that, we're trying to get a CT scan and some imaging in the low back so that we can keep her out of the ER. Now, we can send her to the ER, but it's just, they're just gonna have to redo the work again. I mean, they know the same thing I know. I've done that job. And so they're just gonna have to do that. They're gonna have to go through this whole thing again. And now we're talking about another fee. And so there's this thing in my office, we call it the look. So when I ask my ladies to get this thing scheduled, I get the look back. And the look is, well, this is a patient who has Medicaid. You're not going to get anything approved. And so I said, well, can you do your very best? Can you give it just a shot? And they'll spend 15 or 20, 30 minutes on there and say, you know what, we can't do it. So where do you think it goes? Well, eventually we have to call the lady back. Eventually this lady's got to go to the ER. And now we're into that again. And so that is the specific, but let me give you the moral of the story. The moral of the story, I think, is something like this. I think there are people that believe that when you all put prior authorizations on there, that's going to save you money. I think that in your heart, you really do believe that. But that's just a lie that I think you're telling yourself, because that is not what happens at all. You just pay more for it. For example, when I want something, well, I want to get it done. Now, you may not give me permission to do it, but I'm going to send them over to the neurosurgeon and then they're going to do it. Or I'm going to send them over to the neurologist and they're going to do it. Or I'm going to have to send them to the ER and they're going to do it. And this happens several times a week. I mean, it happens almost on a daily basis. I have to call the ER and tell them why I'm sending them my patient. I'm sending you this patient because I cannot get imaging and you've got to do this. This is why. And invariably, you know, we're of like mind. They have to do the same thing. And so to me, there's this giant hidden cost that nobody kind of, I'll bet you don't even have a handle on it. Is how many times people have to see a primary care person, then they have to go to another person, get a consultation or an evaluation, and then get the same test to get the answer to begin with. And so not only is it frustrating, again, it's demoralizing and it's costing us money. Now, fortunately, I think this year in Kentucky that we've kind of come to a position where a lot of other states have come, where there's, if I'm not mistaken, there's a gold card bill out there, something where if 90% of your requests are reasonable and appropriate, then we'll let you have these things. And I hope that we can come to some type of working position that way, again, for the whole system. Dawn, Ashima, surely you've had some work with this. Can you all comment on your experience, please?
Ashima, go ahead.
So with my Medicaid patients, I think because I am a specialist, I usually don't have an issue getting the MRI. I usually order MRIs for the kids. I don't have a lot of issues, but I see exactly where you're going, and it is so true. And I was just thinking about this month, we've had so many staff out sick, and and across the country, the staff shortages, it just causes more of a problem because, Dr. Thornberry, you're absolutely right. If we want something, we're going to get it one way or the other. And I don't remember one time when I finally did a peer-to-peer with the insurance company that it was denied. It's always in the end approved if I have the staff to go through that process, and then me, myself, making that extra time, staying at the end of the day to do that peer-to-peer. It's always approved. And it's just such a pain to have to go through that process. And then totally agree that in the end, if I can't get it done, that patient's going to the emergency room to get it done.
Dawn?
Yes, I spent at least 2 hours reading everything I could online about prior authorization just for this morning. And it would appear that simply prior authorizations came about in the first place to be sure that we were showing the best clinical judgment, that we were treating patients in the most efficient way that we could, and the best thing for everybody. But it has morphed now into something where it's costing more to deal with prior authorizations. Big office groups have people that do nothing but get prior authorizations. And it's become a money-saving thing, whether we like it or not, on the insurance side. And for those people who have risk contracts, maybe on the physician side. But it looks like we've come to the point where we need to decide, are prior authorizations worth it at this point? Because in several of the studies I read last night, it's now costing more to to police it than it is to do it. And that's why I don't really see that the gold card idea, I think we're past that sort of thing. And as Ashma says, she eventually gets all of them done, and that's going to happen. So I just think a discussion of just forgetting prior authorization. We need the insurance companies to have it. We need to have a big discussion of this, I think. That's what I have to say.
Well, I guess it kind of depends on who's, where you're sitting. For example, if you're sitting in a position where you're responsible for budgets and you can't stretch the bed sheet around everywhere, and you're trying to figure out where you're going to try to save money, I understand the discussion from a fiscal point of view. But when you get in the trenches, again, like Ashima says, well, before they actually get to the ophthalmologist, I want to try to have the imaging that's going to allow her to do her work. Now, how would I know this? Because I've worked with this lady for 15 years. I mean, I understand what they're going to want, or I've spoken to them beforehand. And if I give them, for example, if a patient's got a neurosurgical issue and they're talking, we're going to consider surgery or not, they're going to want that MRI of the lumbar spine before they walk in, because if they don't, they're going to say, how you doing? Go get that MRI and come back here in a month and we'll talk about it. So the things are going to get, that it's not that they're not going to get accomplished, they are. Now, can you split the hairs in saying, well, again, can you go to these maybe clinics, and should the maybe clinics should they be ordering stuff? Well, I don't know about that. I can only talk about traditional bread and butter primary care, where these people are committed. These are like the lifelong people that are committed to, say, any institution, say even DMS. You have people that are there lifelong, and they work there every day, and they're there year after year, and they kind of understand the way the system works and what's going to be efficient. Well, your primary care workforce, again, they're committed in the long term. They're committed to these communities, these patients. And I think you're going to, at some point, it's going to be like CMS. You're going to have to trust them to either do their job or they can't do their job. And, with CMS, with traditional CMS, I don't have any trouble getting things. And, when I look at my reports every year, it doesn't look to us like, we're overspending or doing things, anything inappropriate. There's a certain amount of things that have to be accomplished. So I guess I want to get away from the whining on this. I just want to try to help you guys understand what the problem is that we can't do our work. Again, Dr. Neal pointed out that we have somebody in our office that we're paying. Nobody's paying for this. When you do a prior authorization, you don't get the bill for that time. They're on the phone or they're on the computer trying to get something approved that we already know is going to have to be approved. And the question is how long are we willing to go with that? Are we willing to go 5 minutes, 20 minutes, an hour? And several of these things it takes a long time. So I think eventually we just get demoralized and we give up like everybody else does. And we either send them to the ER or we send them to a lot of specialists won't even take them without the imaging. Like you can't do that, or we explain to them, or there's a hidden agenda. Like we say, well, we know you want the we know you want the imaging, but we can't get it. You're going to have to order the imaging. And they do. They go to Ashima or somebody like Ashima, and they get the imaging, and then they come back and do another appointment. So I want you to understand from our point of view, when it comes to prior authorization, how difficult that is making our job, so that when this comes before you, because at some point when this legislation works its way through, someone from your end is going to have to contribute some information to this process. And I don't think unless you sat in our shoes for a mile, you would really understand that. Again, I don't want this to be I don't believe in whining sessions. I don't think they accomplish anything. But I hope that you can understand the frustration that we're having in trying to solve the problems you've asked us to solve. You've asked us to solve these problems, and we don't have the tools to do it. I'll just open the floor up at this point. I think we've kind of made our presentation. If anybody wants to chime in or has an idea.
I can make one comment. I was just thinking it would be interesting to do maybe a study, if DMS agreed to get rid of the prior authorizations for like 5 years and compare the data. That's just a philosophical statement.
We've got some MCOs on the Zoom right now. I see Aetna, I see Anthem. Could we have them give us a little bit of their perspective? They must be having internal discussions of prior authorizations. They must be dedicating a lot of time and money just to dealing with it. Can one of them speak up?
Yeah, this is Ken Groves with Anthem. So I will tell you, I do hear the concerns that have been raised, but what we've done with Anthem is that we've tried to make the process a little bit smoother by presenting on our digital tools, doing authorization via availability to speed the process whereby the providers do not have to spend so much time over the phone to make it more digital. So that's what we've done at Anthem to try to ease some of the burden, administrative burden for the providers.
Okay.
Good morning. Good morning. This is Dr. Cantor with United Healthcare. Along the same lines, we have a similar portal available online where the clinical information is entered and a decision can be rendered right then and there. If it's an approval, if it becomes a denial, then that would go through the typical process. But that has been, it's available. And if you need more information about that, I'm happy to share that. The other aspect of this is managing populations, which is what we are tasked with, is when we look at it from a population health perspective, there is enormous variation in clinical decision making, whether you look at allergists or obstetricians and anybody in between. There are not, unfortunately, appropriate standards of care that is met consistently by physician from physician to physician. And therein has been the rub, in that because there's such variation, it's because physicians, and I'll include myself as one, have not been policing ourselves well enough. It's created this managed care opportunity, and we can go down this whole historical bent, which I really am not trying to do. But my point is that unfortunately, there are physicians who do not practice to the highest levels of standards of care. And that's part of the process of having a PA. Thank you.
Thanks, Steve. This is Dan Brunner from Anthem, and I second those sentiments. First, I feel that I'm an emergency doctor. I feel the frustration on our end when a member or a patient who needs a certain test done cannot have that done, and end up in the emergency department when the ER provider, why couldn't this get done electively as an outpatient like the doctor wanted, when they get a roadblock with the prior pathway. I think my advice is, when we're reviewing claims for prior auth, a lot of times there's not things clearly documented as far as what the guidelines require, a change in neurological exam, increased frequent falls, or focal finding. And my advice is please clearly document those things to speed the process. We're always available. Obviously, we do peer-to-peers and when appropriate overturn things, but I think part of the PA process was designed to cut down on the waste. And the vast majority of physicians are not wasting. They're not in that category, but there is a percentage that are, and we're trying to, better care, lower cost, and part of the process.
I'd like to thank our MCO colleagues for their insight. My takeaway on this is, unfortunately, that I think what might be happening is you're letting the exception make the rule. I think there are a great many people that do follow the Choosing Wisely campaign and do take their work very seriously and are trying to work with not only you guys, but the entire system to make this not only efficient, but sustainable. I think there are some people that may not be fully competent in the roles that they're in. I think they may not be competent in the literature. But I think unfortunately what happened is my gut is, having worked in this field now for about 25 years, is that those people are now making the entire rule for everyone. And it's causing, it has become to, it's, again, I know that you all believe that you're saving money. But you know what I would like, if I was in that job, you know what I'd like to do for every denial, I would like to go back and find out when I had a denial, I would like to go down and look, say 3 months later, what did that patient eventually end up having it done? And how many people did they have to go to get that thing done? Because I'll bet you, again, much like Ashima, when we want something accomplished, it's going to get accomplished. Now it's going to take more money and it's going to be more problems. It's not going to be as convenient, but it's going to get accomplished. If we have to have imaging, it's going to have to be done by the specialist. And then they're going to have another appointment to discuss it. Or it's going to go over to the ER because we can't get it today or tomorrow, or they have whatever it is, 72 hours to decide. So I think it's unfortunate. And hence, I think that's why we're talking about statute today. That's why we have something in front of the legislature, because we can't work this out ourselves. If we could, I guess we would have already worked it out. Are there any other comments before we finish up? I don't see that talking about this any further is going to accomplish anything. Ashima, Don?
This is, if I may, this is Angie Parker with Medicaid. I just wanted to say that, you know, in the past 2 years during COVID, we have waived prior authorization on a lot of services, and currently it's still waived on behavioral health. So we have been looking at that. I don't have all the data in front of me as far as what that's looked at so far, but we are looking at the data of where we have waived PAs, and should have more information on that at some point. But generally, we have seen an increase in services without the PA. But again, I don't have all those specifics here to provide you, but it is being evaluated by Medicaid.
Thank you, Angie.
You're welcome.
And I want to go on firm record here to say that the people that don't understand the imaging that they're ordering, that don't understand this, that are not competent, I don't think they should be doing it. I was going to say that up front. You know, I don't think that people should just be, you should just be able to order whatever you want, to whomever you want. I'm not saying that. What I am saying is we need to try to find a system to allow the people that are doing the work for you guys to do their work, and do it in a way that is still addresses the principles of population health and accomplishes the work on the front end, so that people like us can try to help you guys. Don, Ashima, do you have anything else before we close it up here?
Not about this, but
Yeah, we still have another item, don't we?
yeah, it's not on this agenda.
Yes, we do. But we do have the item.
Okay.
And that would be item 3. Cody, do you have that for us? It didn't make this, but we did approve it.
Yes, that was the, Dr. Gupta wanted to discuss the Medicaid coverage of serum tears.
Yes, thank you. So actually, the Kentucky Academy of Eye Physicians and Surgeons reached out to me last week because I guess apparently serum tears are not currently paid for by Medicaid. And I asked them some follow-up questions, and unfortunately I still have not received that feedback, but just to give a little education about that, the serum tears are basically using a patient's own blood, and it's just spun down and made into a teardrop form, and it's used in severe dry eye, especially in patients who may have certain autoimmune diseases and have failed all other dry eye treatment. It's kind of like a last resort type of treatment, and it can be very successful. So I asked them, you know, I don't know how much the out-of-pocket cost is that for a patient, and I'm still waiting to hear back on that. And I guess we could probably table this until the next meeting, but if you have anyone from DMS has any other questions that I could pose back to that group, just so I could, you know, better give a recommendation at the next meeting, that would be great.
Dr. Cooper, this is Charlotte, and I definitely don't have questions because I'm not familiar at all with this. But I mean, since this is a question regarding coverage of a procedure and stuff, if you could provide me with that information, once you get it from the association, we can go ahead and start working on looking into this and maybe have you an answer by the next meeting. Or
Okay.
before that, instead of you waiting till the next meeting to give us the information. So
Okay,
just
that would
thinking,
be better.
yeah, if you could get all that to me, then I can get it to the policy folks, and one of those would be Justin. And we can start looking into it and know what we, maybe be able to give you a heads up even before the next meeting.
Okay, that would be great. Thank you, Shirley.
You're more than welcome.
That's all
Well,
I had, but sorry.
very good, Ashima. Is there any new business today then? No new business? So let's take a look here. I don't think we need to do any recommendations for the prior authorization because I think we have something before the legislature this time. I certainly want to appreciate our DMS colleagues working with us on the telehealth program. There's nothing there. Do we not have, Cody, does anybody recall if we have something before the MAC? Ashima, do we have something before the MAC on complex E&M? I thought we already did.
I think we did, I feel like 2 meetings ago, 1 or 2 meetings ago.
I think
we did.
so. And with the department kind of working on that already, I think, I don't really want to press that button any further. I appreciate them helping us. And so I think that I'm not going to recommend any recommendations at this point. Our next meeting is, let's see, is that correct? Friday, March 18th, 2022. Is that the right date?
I'm looking here just to verify.
I think so. I didn't check it before I got on though.
Oops, I went too
Dr.
far.
Thornberry,
Yes, ma'am.
I'm sorry. I think we did, at the last MAC meeting, I think we did make a recommendation about the contact lens coverage for adult patients. And I'm not sure if we heard anything back from DMS yet. So we could just ask if they could follow up on that.
Yeah, I think what we'll do is we'll just kind of, Cody, just kind of bring that in as old business so we can just kind of just do a quick catch up when we have our next meeting on item number 1, which is the complex E&M, and that way we can see where our colleagues are at. Okay.
Okay.
All right. If there's nothing else, I'll ask for a motion to adjourn.
So moved, Dr. Gupta.
Dr. Neal, I can't hear you. I think you're muted.
Can you hear me now?
I can hear you now.
Okay, sorry. Somebody muted me. Wasn't my wife. I don't know who it was. But anyway, when is the next MAC meeting, and is it real or virtual?
The next MAC is next Thursday. Let me get back on the 27th.
Yes,
And it is virtual, yes.
it's virtual. Okay.
Yes.
Perfect.
I think
So-
they voted to do their January and March meetings virtual, and then would look at March, whether they would do the
Okay.
May meeting in person or virtual.
Okay, that's fine. So I would then move we adjourn. That's what you would like, Mr. Chair.
Yeah, I think so. Thank you, everybody, and enjoy your weekend. Okay.
See you later. Thanks. Great job.
Thank you.
Okay. Bye-bye.
Bye.